Good afternoon, members. It only takes 3 members to form a quorum, so we can start the meeting. Item 1 on the agenda, selection of chairman and vice chairman. I would like to consult your views as to whether we need to re-elect a chairman and a vice chairman. We have 2 eligible candidates, Albert Ho and Joseph Lee. You can comment on whether there is a need to re-elect the chair and the deputy chairman. No need? No need. Mr. Ho, any comments? No need. In other words, I'll continue to chair the meeting. Is there a need to elect a deputy chairman? Is there a need? No need. Save the trouble. This is not a meeting of the Welfare Services Panel. Rather, this is the meeting of the Subcommittee on Health Protection Scheme. That's item 1. Now we come to item 2. There is an application for late membership. Mr. Vincent FANG and Mr. Charles MOK would like to join us. I personally think that is fine. What about other members? Support it? All right. Welcome, Mr. FANG, Mr. MOK. Welcome, so that we can study the issue of health protection scheme. Item 3. Progress report on the commissioned study on healthcare manpower planning and projection. I would like to invite the government officials to join us. In relation to the healthcare manpower planning projection as well as the regulatory framework, the administration has commissioned the Hong Kong U as well as the CU Hong Kong to carry out the work. Hong Kong U covers the healthcare manpower planning and projection, while CU Hong Kong is responsible for the regulatory framework for healthcare professionals. They haven't got the final reports. Earlier on, we said that before they are ready with the final reports, we would like to ask them to come and tell us how they go ahead with the study. So today we are glad to have the representatives from the CU Hong Kong, especially Hong Kong U, to brief us on their studies. In a moment, we will first talk about the study on healthcare manpower planning and projection. That is the one by Hong Kong U first, and then we'll move on to the regulatory framework. Administration and the university representatives, welcome. When you're ready, I would like to give the floor to the administration to walk us through the paper. Thank you. At the March meeting this year, we briefed you on the progress about the healthcare manpower planning and professional development. We mentioned that the Hong Kong U as well as CU Hong Kong have been commissioned to carry out the work. For today's paper, this is to keep you abreast with the progress of the review. The Hong Kong U is now preparing a model that suits the local needs, and this is a generic one, but which will be sort of adapted to future changes. We'll look at historical utilization data, we'll look at population growth, demographic changes, so that we can project the future manpower demand. For CU Hong Kong's study, it has been found that in many places in overseas countries, the regulatory framework is moving from self-regulation by the profession to co-regulation in partnership with the public, so as to go for more openness and accountability. This is a global trend. In order to maintain the professional standards, continuing professional development has become mandatory. In some places, they've also moved further ahead and have come up with ideas like revalidation and recertification. And then the investigatory and disciplinary functions, they are always and often separated and organized independent of each other. And turning to healthcare graduates from abroad to help address short-term manpower shortages at home is not uncommon. When compared with overseas countries, our characteristics is that the regulatory framework has a high degree of professional autonomy. The regulatory councils and boards are mainly composed of their peers, and they are being funded by public money as far as the Secretariat is concerned. Apart from a few disciplines, we do not mandate continuing professional development programs. For returnees from overseas, generally speaking, they have to pass a licensing examination before they can be fully licensed to practice in Hong Kong. Now, manpower projection and planning is more complicated. Hong Kong U thinks that it will take until 2014 before they can complete with the manpower planning and projection for all the 13 disciplines, but they think that they can finish with a few of them earlier. For CU Hong Kong, they have to take into account the views of the stakeholders, and we aim at completing the strategic review within the year 2014 to enable members to have a better understanding of the progress of the two studies. We have invited the university representatives to come here. That is Dr. Johnston and Dr. Yo, respectively, from Hong Kong UNCU. With your leave, I would like to invite Dr. Johnston to tell you about the model concerning manpower planning and projection. Thank you. Mr. Yun. Well, I think we should talk about manpower first, and then we'll talk about regulatory framework. So Dr. Johnston first. Yes, Dr. Johnston will tell us about the model developed by Hong Kong U. Dr. Johnston.
Sorry, I hit the wrong one. Good afternoon, Chairman. Thank you. Today I will present for you the conceptual demand and supply model for the healthcare manpower projections and illustrate how these two models will be used to quantify the manpower gap. What I will present is a generic model, as has been said earlier, and this generic framework will be used to apply to all the healthcare manpower groups that we are looking at. But for today, I've used the doctor demand and supply projection model as an example to illustrate our purpose in going forward. The purpose of the model is to project the number of doctors, which are expressed in FTEs, down here, expressed in FTEs, to look after the healthcare needs for the total population to be served. So we're starting from the total population, and what we want to end up with are the number of doctors expressed in terms of FTE. Healthcare needs in this model are defined as realized demand or the service utilization within the population. So everything we do will be within the service utilization framework. The Anderson Health, Behavior, and Access to Care model provides the underlying framework for the model, and this access to care model organizes need in three main components: predisposing characteristics, enabling resources, and need. The predisposing characteristics includes factors that underlie or predispose an individual's use of health service. The enabling resources provide us with the means by which we can use health resources, and need, both perceived and realized or evaluated need, are the strongest predictors of all health service use. And although there are many other characteristics that can be used within the Anderson model, The ones that we've expressed on the screen here are those we have chosen to use because they're the most consistent with and enable comparison with work the School of Public Health has done for the government previously on cost projections for the health protection scheme, the healthcare financing, and the long-term planning models that were prepared in conjunction with the Elderly Commission. The data used in the model will come from the thematic household surveys, the Hospital Authority, the Department of Health, and from data from private hospitals. And the validity and reliability of this data has been well established. Collectively, the data will be fit into a neural network, which is expressed by this little widget here. And this converts this information into the FTE framework, which is what we're trying to accomplish for you. The derived utilization is drawn through the FTE widget, the neural network, and then gives us this the number of projected FTEs. Service utilization is also influenced by externalities, and these externalities can have a positive or a negative impact on utilization and can have a cost or a benefit in terms of population healthcare use or cost of the healthcare delivery. And there are three important externalities to be considered. These are technology diffusion, productivity change, and complementarity and substitution. Technology diffusion is just as you might expect as we become more advanced in our application of different types of devices and different types of products. Our service delivery model changes and the way we manage patients change. Productivity change obviously comes mostly through efficiency gains and through the way we manage our healthcare service and the way we deliver our care. Complementarity and substitution you can see in many parts of the world through the differing ways that healthcare workers do their job. And we need to consider different aspects of complementarity and substitution in terms of full-time equivalent requirements. What I have described is the core demand model, and this model will then be stratified to project FTE requirements by service type, either for inpatients or for outpatients, and by sector, whether in the public or the private sector. The inpatient sector service utilization will be expressed as the projected number of discharges and the total number of bed days. And service utilization for the inpatient sector will be stratified by diagnosis-related groups and by service sector. Projections for the outpatient sector follow the same principles. However, the outpatient sector service utilization will only be expressed as the total number of visits, as diagnosis or reason for attendance is not broadly available across sectors. Visits will be stratified by service specialty and by service sector. Though the elements in the demand model are consistent throughout, the externality assumptions will vary by service type, whether they're inpatients or outpatients, as obviously the technology diffusion, the productivity change, and complementarity and substitution vary by service sector, whether it's inpatient or outpatients. I will now switch to the supply side of this equation. Again, this is the conceptual model, and it will be applied to all healthcare professions. As with the demand side, the objective is to project FTEs, this time from the pool of available healthcare professionals, which includes both the newly eligible and the pre-existing registrants. The newly eligible registrants derive from two sources, local graduates and non-local graduates, and become part of the total registrants pool. Pre-existing registrants are those who are already registered, as not all who will register pass through the renewal proportion. The widget will pass through the renewal proportion widget to join the registrants pool. Although a doctor may re-register, they may not be clinically active. the total number of registrants pool will be reduced by the number of clinically inactive doctors. These are doctors who are no longer in medical practice but not retired, are retired, or are otherwise deregistered. The result is the number of clinically active registrants stratified by specialty and by service sector, and this reflects the total headcount. To derive the number of FTEs, the clinically active pool passes through the widget for conversion to FTEs. This widget accounts for the workforce participation rate and converts the headcount to FTEs considering the male to female working hours ratio and preference for part-time work otherwise. The supply model will also consider externalities, factors that incur an additional cost or benefit. And these externalities work through the workforce participation rate and include the differential capacity and work pattern by service sector, and standard working hours and/or other overarching policy change which will impact the production and supply function. In the next series is an example of the time-dependent or recursive nature of the projection. First, the supply side. Beginning with the 2013 pre-existing registrants and the newly eligible registrants, we can estimate the number of registered doctors. These are then split by those clinically inactive and active, and the clinically active are converted to FTEs. In 2014, the number of registered doctors becomes part of the pre-existing registrants pool, and the same process is followed through. So that's a continuing process throughout the projection period. This recursive process is followed for the period of the projection, and here we have projected the FTEs for 2013 through 2016. As for the supply model, FTE requirements are projected for the demand model. The FTE gap between the supply and the demand model is then calculated. Obviously, these do not represent real figures, but they're just an illustration. Balancing this gap is the trick and requires change in both control knobs as identified in both or either of the models. Lastly, I want to place our approach in the context of current practice. 4 major approaches are commonly used, each with its own advantages and disadvantages. Needs-based models take a more normative approach and subjective approach and are less practical than what I have presented. They are very data-dependent. Demand utilization models are more practical and take a more objective approach and project requirements from realized need. That is need that is expressed in utilization. So it's more readily quantifiable and more readily verifiable. Benchmarking is simply a population ratio and lacks the sophistication necessary to estimate manpower requirements in a complex medical economy, but is very useful in terms of placing any country or system as a measure with another group of countries or systems. So it's a useful benchmark, but it's not good for projection. Trend analysis is based on aggregate level time series historical data. It's a macro simulation model extrapolating from past trends. The model presented here is a micro simulation model that is essentially demand utilization based. We will take a more macro approach to the projections and use trend analysis and benchmarking for the sensitivity analysis in future stages of our work. Thank you. That's all I have to present.
Okay, 唔該晒 Dr. Johnson.
Thank you, Dr. Johnson. Now the floor is open for members to ask questions. Last year, we only timed members' speaking time and not officials' reply time for the sake of efficiency. So members don't have to ask too many questions in order to use up your time. Now, if you spend 1 minute on your question, even though the officials have spent 10 minutes, well, you will still have your 1 minute left. According to our experience last year, 3 minutes is already very long just for asking questions if we do not count replies. So let us try with 2 minutes first. Okay, so I think if 2 minutes for asking questions and then we do not time the officials' reply time, I think each member would take about 5 to 7 minutes. And when we have internal discussions, the timer will not work, okay? All right, you have just heard Dr. Johnson's PowerPoint presentation. All right, do we have any questions so far? If not, I will start the ball rolling. And then when I see any hand, I will start the timer, okay? So members have no questions for the time being. My English is just so I will ask in Cantonese. And so Dr. Johnson might have to wear the earpiece. Still, my Cantonese is also so I may have to use 1 or 2 English terms. I understand there are different ways for projecting manpower. I'd like to know whether you have a feedback mechanism in your model, so that when there is any discrepancy between the reality and the projection, you can adjust it very quickly. Because this is mainly a projection model. So you take a snapshot of what we need, say, in 5 years' time. And you make projections on service demand, which will be affected by a number of factors. So it is just a projection model. I'd like to know whether there is any mechanism for adjustment as soon as possible if the projections are found to be wrong. Yes? Theoretically speaking, the question was for the PS. All right, he defers to you.
We've been asked by the government to provide a projection model, and that's what we're doing, providing the projection. If I understand your question correctly, you're asking if there's a way to test the model for its accuracy in sort of 5 years' time. Is that correct?
Something like that.
Not to test its accuracy. Now, for all models, there are bound to be errors or deviations. Assuming that you've come up with the projection that 5 years down the road, we need 15,000 doctors. But there are bound to be deviations. For instance, the 95% company interval, assuming that your projection is 15,000 doctors 5 years down the road. If the confidence interval is from 30,000 to 50,000, then the accuracy is very poor. What's the point of having a projection if that's the case? So, in addition to a projection model, you must have a mechanism to very quickly adjust when there is any discrepancy discovered. You must have a quick way to readjust the supply of doctors. Is there anything in your model? Have you taken that into account in your doctor? How can we adjust the projection?
We have. The model is based on historical data and on as many years of historical data as are reliable and valid. And for the most part, that's about 8 years of data. The model can very quickly adjust to changes in any new data that is fed into it at any time. So it's designed to be able to pick up new data on a rolling basis. So as new information is available, new information can be added to the model. It doesn't have to be regenerated. So yes, is the answer. It can quickly adapt to changes that are available and represented by the data.
嗱，你若果話一有新嘅數。
All right, whenever there is new information, the model can readjust at once. Does that mean that the mathematical tool will? Does that mean that the mathematical tool will be handed over to the government, or will it be open? The tool. Let's say the projection is 5 years afterwards, we need another 5,000 doctors, 5,000 more doctors. Come next year, new medical graduates cannot find jobs, for instance. Can that new data be fed into the model by the government or any stakeholder so that at once we can adjust, or we can tell that 5 years down the road we don't need 5,000 but only 1,000. After developing the model, will it be handed over to the government and can it be open to the public? Chairman, can I supplement? That's exactly the purpose or objective of the model. In the past, we made a projection about the demand 10 years down the road, and that's it. We don't want to see that again, and that's why Dr. Johnston referred to a number of widgets. They have main factors affecting manpower supply, such as the number of graduates, the number of retiring doctors, and also clinically non-active doctors, and so forth. So the purpose is after the model is developed, it will be handed to the administration. Usually for a model, the effect can only be seen after 5 to 6 years. We intend to consider the discrepancy every 1 to 2 years. If the discrepancy is not high, that means the projection is rather accurate. If all of a sudden the demand has surged, or if many medical graduates have failed to find a job, then we can at once review which part has gone differently from the reality, and then we can rerun the new data, input the new data. You talk about self-fine-tuning by the model. So this is a new way of making projections. All right, just one more sentence. Although you say that this is a very complex issue, still, no matter how complex it is, there are many people in Hong Kong who know how to do the analysis. Well, the neural network referred to by Dr. Johnson, I started doing that in 1997. I know it well. So can you make open that model for the public for two purposes, so that we can all see for ourselves how good the model is, and we can also provide input, and secondly, to allow the public to monitor. When we are looking at the same model, let's not dispute. We will use the same model. After all, this is no secret. Once the model is developed by the university, it can be handed over to the government, and it can also be made public so that we can all monitor how effective the projections are.
I understand what you're going after, but we try to see how it can be done. Because after all, they're computer models, but computer models are still developed by human beings. Yes, we will be making announcements when the projections go wrong. No, don't make announcements until it is discovered that there is something wrong. Please tell us about, please give us the tools so that we can monitor together. Well, because it's something that is being run all the time within the computer system. Mr. Vincent Fang. Thank you, Mr. Chairman.
For us to ask questions in English or in Chinese for you?
Either way.
Okay, according to your model, okay, do you take in consideration of a couple of factors? One is our aging population, and second is as the people are getting older, I think the complications of their cases will be more complicated, probably require more time. And the last factor is also the consultation period for a doctor to see the patients. Because right now in the public, the clinic, the consultation time they give is very, very short, less than 5 minutes per patient. So do you consider that yes, still using 5 minutes or maybe a little bit longer in your model calculation?
The Chairman, the model draws on data that is available from both the public and the private sector. And the public sector and the private sector data are enable us to assess both the age-specific changes in the population because we're using the census data and the census age-specific projections, and also we use the public sector and private sector data for estimating workload. So yes, we can do both. We can both adjust for population dynamics and we can adjust for different characteristics of work within by sector.
So actually all these three factors you have already put it into your model.
Yes.
Okay. How about the consultation period that you use? Are you using still 5 minutes or a little bit longer in the future?
We use the data that has been reported by doctors in the Health Manpower Survey. So as they have reported their information, we have used it.
Thank you.
Well, you put age in the first one.
The predisposing characteristic.
Yes.
Number one, age, sex group. Okay. What about the consultation time?
The consultation time comes
Where do you put it?
The supply model.
Yeah.
In the supply model.
In the supply model. This one.
Yes.
Where?
In the preference for part-time work, in the workforce participation rate. It is included in that factor of the workforce participation rate.
Workforce
Here,
participation.
right here. Well,
No.
use most
Consultation time means
yes.
in the past, a doctor will spend around 5 minutes to see a patient. Well, you expect in the future our patient will expect 10 minutes or 15 a longer time. That will use up more manpower.
Yes.
That is, how can that be explained in the workforce participation rate?
We are using current data that is available from the Health Manpower surveys and any scenarios that we want to draw on to project different policy initiatives or changes in practice can be fit into the model.
秘書長嘅補充啊。
主席，我咁樣補充啊，方。
Allow Mr. Yun, let me supplement. Well, this is a very general concept model, like the workforce participation rate. what has been done is that we've looked at the current situation, like the workload of the doctors currently and also the consultation time per patient. To answer your question, we haven't anticipated a lengthening of the consultation time from 10 minutes to 20 minutes, for example. But then the model does allow us to make some changes. But then, say, for example, we can test it. If we are to lengthen the consultation time by 100%, then the model would tell us as to how many more doctors we need. Now, they are from the university. They are not here to tell us as to whether 10 minutes or 20 minutes are desirable. But then the model that they have developed for us enable us to do so. That is, say, if we have the resources to allow us to prolong the consultation period, we can fit in the data, and then we can say that, well, in that case, we need 15,000 doctors. If we are to lengthen the consultation time even longer, then perhaps we need 17,000 doctors. Well, you are talking about a model according to current data. Now, if the model is okay, then the three factors that I referred to, that is, the population is aging. So you will fit in the rate of aging. And then say the conditions are getting more and more complicated. Again, you can fit that in. Yes, already. Now, for the consultation time, currently it's 5 minutes. And I hope that in future it can be longer, say 7 minutes. So I hope at least you would fit the three factors into the model so that you can understand the gap. Now, the university will only develop the model, but if they don't fit in the data, then we can't see anything. Mr. Chairman, allow me to answer Mr. Fang's question. Now, demographic changes and also aging of population, they are facts and they are quite accurate. They have already been fed into the model. As to the growing complexity of the conditions, again, they are known. As to the consultation time, it depends on the decisions as to how much you want it to be. What they are doing is to base on the current arrangements. Now, we are here to talk about the components of the model. The figures haven't been sort of run out. That would be for the next time. Next time we'll run the figures out and then we'll brief you and explain to you as to what the picture is going to be like in 5 years, 10 years down the road. Here we would like to get a briefing from the university. We want to get an idea of the progress. We haven't got the figures coming out from the model. Well, if you feed the current data into the model, and you know the gap, that is the number of doctors that we are short of, I want to know whether this is compatible with the earlier projected shortage. Do you have the figures? No, we haven't prepared the figures. They are still developing the model, the programming. Once they're ready with the computer program, they still have to test it. So we use the data 10 years ago, say, for example, to check whether it is accurate. And then later on, we'll use the prevailing data and also the projected figures like population, age distribution, etc. Then we fit in the data and then we run out the figure. We run the figures and then we will explain to you as to how many doctors we need in the future. So that would be in the second phase. So currently, we haven't got the figures. I will allow you to follow this up later on, because we need to follow the House rules. Albert Ho.
To ask you a question concerning the 4 separate approaches contained in number 12 of the slide of the PowerPoint. Okay, the 4 separate approaches. Now, I have looked at the factors, the various factors contained in the column basis for consideration. Okay, now all this appear to me to be highly relevant for us to formulate our policy in long term. All these are highly relevant. For instance, but the difference between these 4 separate approaches is that number 1, number 3, and number 4 seems to base on what we ideally want. Okay, for instance, socially optimal number, standard of care, and historical. 1 and 3 are prescriptive, more or less, what we want. But the second and the fourth one seems to based on practical constraint, like number likely to employ and historical trends. All these are facts, okay? Factual consideration. Now, can you tell me whether all these four approaches are mutually exclusive? Can we combine some approaches as a certain approach with another one, such that what we consider to be pertinent considerations could be included in the approach we finally adopt?
Yes. You guys ask yes, no questions. The answer is yes. The needs-based model, as I said earlier, is probably the optimal model in many ways, but it requires subjective data and is difficult to verify. And for that reason, and because not all relevant data are perhaps available in Hong Kong at this time for this model. So for that reason, we have set that model aside. The demand model, the demand utilization-based model, which is what I've presented is based on, is a more quantitative model. And because it's a more quantitative model and it draws on very verifiable data. So from your point of view of preparing policy for Hong Kong, it gives you a more secure basis for that because the data is much more quantifiable and verifiable. I agree that benchmarking and trend analysis are very useful and will be used to cross-validate or triangulate the demand utilization-based models. So we will use them, but the core projection will be done on the demand utilization-based model and triangulated with the benchmarking and trend analysis models.
I see. 我想跟住問秘書長咧，咁目前而家我哋
If I may ask a question, Mr. Yun, I think even the hospital authority has got some manpower planning and manpower projection. What sort of model, what sort of methodology have they been using? Now, Dr. Johnston is basically using the demand utilization-based model. Are they the same?
I believe you are in a better position to assess whether the HA's model fit in any one of the four, because I think they have their
it's
own...
It's a demand utilization-based model, essentially.
Modified demand.
It's the current model.
Yeah.
It's a modification of the demand utilization-based model. Our models are actually very similar.
I see.
或者主席，我補充一下咧，就係
Mr. Chairman, allow me to supplement. Mr. Ho raised a very important point as to why we have spent so much time on this. Now, regarding the projection for doctors, now we're looking at the entire society. The HA has taken up is accountable for a majority part of the picture. So we want to dovetail with that of the HA. Now, HA is looking at the modified demand. So while they look at a demand-based model, they would ask individual service, individual departments to look at their demand, and then they aggregate them. So it is quite similar to the demand model, but they have made certain adjustments to suit their circumstances.
Dr. Joseph Lee. Thank you, Chairman. So Hong Kong U has developed a projection model hoping to assist the administration to accurately project the demand for personnel in the coming decades. Of course, I respect this model this approach by the academia. I have a few questions. As pointed out by Mr. Albert Hill, well, the HA has also come up with certain projections. Now, I don't know about doctors. I'm a nurse, so I know about projection for demand for nurses. Now, if we use this slide, if we use the different approaches in this slide, assuming that we use the benchmarking approach, or we may use the need-based approach, I'd like to know now, internationally, we all say that in an acute ward, the ratio of nurses to patients should be 1:6. I'd like to know whether these approaches will come up with the same projection or the same manpower need. And now, this is a conceptual demand model for health professional. I'd like to know whether you are talking about a tertiary level, that is hospital services only. Can it be applied to the primary and secondary levels? Chairman, as Dr. Lee said, if we use a benchmarking approach, then we will go by a rather subjective, will come over rather subjective ratio. So there will be disputes, and it's also about rational use of resources. And then the hospital situation does differ from jurisdictions to jurisdictions.
Get the rest.
Yeah. What I'm saying that honorably is referring to the projection for nurses,
yes.
Not doctors, nurses.
Yes, I understand.
He just take the example that if you use the benchmarking, that means you have to pick a ratio, and then based on the ratio, you can assess the long-term demand.
Yes.
I just explained that the problem with benchmarking is that it's very subjective in picking a ratio, because there will be a lot of argument and disagreement, etc., etc., etc. And also, you got to take into account the local situation, the hospital setting, because different places or different setting, the ratio may not be that appropriate. So I'm just saying that for this reason, the Hong Kong University is helping us to make reference to all these the sort of different approaches to models, yes. And then try to find a way that best suit the Hong Kong situation.
Yes.
So that is the whole purpose, yeah. Of having this independent study.
Yes.
For us. And then the second question asked by Honour Lee is that whether the projection will capture the primary and secondary care. Because I just at that point trying to touch on that. I believe that we will do that. Just like doctor. I mean, we're not just focusing on the hospital authority doctors, but the whole Hong Kong, including private practitioner, family doctors. So there's a primary and secondary. The same will apply to other discipline, particular in respect of nurses, because one of the key pressure points from the aging population would be the demand for nurses, not only in hospital, but also in elderly homes and even at individual private homes, because as in future there might be more individuals who are able to afford having their own nurses taking care of them when they grow old. Okay.
Do I still have time? No. Mr. Chan Kim Po, I'm in a hurry to go for another meeting. Now, I have no strong views on the major principles. I am a layman. I don't know how to comment. I believe Hong Kong U has got a recognized method to do that. My question is for the DS. We need to ensure adequate supply of manpower, regardless of what models you use. We all know that we have a shortage of healthcare personnel in Hong Kong, and it takes time to train medical personnel, for instance, 6 years to train a doctor. You have already got the statistics about the coming number of graduates. So even without this model, you can easily say that we need a lot of manpower in the healthcare sector. So I'd like to ask what medium, short, and long-term measures we have to ensure that we have enough doctors in Hong Kong to maintain the services we need. For outpatient services, it's okay. As Dr. Leung said, many doctors have the resources and time to provide outpatient care. But when it comes to hospital services, surgeons carrying out operations, for instance, how can you ensure that we have enough doctors to meet our demand? Thank you. All right, we'll focus on doctors first. As Mr. Chen said, the projection will be about the demand for the coming 6 or 10 years. That is in the long run. It will more accurately help us to project the future demand so that we can be well prepared beforehand. And yes, doctors need a long time to train, and you have to accept that we don't have enough doctors now. So for the short and medium term, we're not waiting for this model in order to act. You may have heard that starting from last year, 21, 12, 13, we have boosted the number of medical places by 100, from 320 to 420 places. And not long ago, the Medical Council announced that it would have 2 licensing examinations per year to facilitate overseas trained doctors to come back and sit for the examination. So these are short and medium term measures. Another round of examination in a year is a short-term measure. More medical places is another medium measure. Increasing the number of places will depend on whether the 2 universities have the capacity to do that. Well, you have 38 seconds left. I have to attend IAC, so may I be excused. I'd like to follow up on Mr. Vincent Fang's question. Whether these models work will have to be tried out. We have to keep feeding in data to see whether the model is accurate. Right. I'd like to ask the PS, where can we fit in information on time, consultation time? Now, let's say one factor, one of the predisposing characteristics is age, sex group. If we have more in this group, that means this is about aging population. But what about consultation time? Where can this data be fed in? Dr. Johnston?
Can I help?
I mean,
yes.
Because I think there's a very simplified presentation of the model, so there might be some certain widgets where you can input the doctor
consultation time belongs to the supply side of the equation, not to the demand side of the equation. The demand side of the equation, it looks at the demand coming from the patient side, right? The healthcare need side, okay? And the consultation time belongs to the supply side of the equation. That's why I said we would, if we're going to model FTE requirements related to by consultation time, then we would add it to the supply side. We would factor that into the supply side of the equation. Because that will increase the supply requirement.
秘書長可唔可以解釋下點解會係 consultation？
Can you explain, PS, why consultation should be fed into the supply side instead of the demand side? I think you're right in saying that it can be fed into both models. By supply side, the assumption is the working hours, the number of working hours of a doctor per day. Now, if you change the consultation time, then instead of seeing 10 patients a day, a doctor might be able to 15 patients. Now, this is the supply side. Each doctor can see 15 patients. I think Dr. Johnston is saying that, well, take the workforce participation rate, only a few factors are mentioned. I believe this is not a exhaustive list of the assumptions. I think she's talking about the total number of working hours per day, per week of a doctor. Now, if we compare this, now for outpatient, you have a service utilization in the middle, and that's the total number of visits, stratified by specialty and by a service sector. And you use that to project the number of patients. And then you use it to convert to full-time employee, to FTEs. So if the consultation time is longer, then the FTEs will be higher. So I think that's where the consultation time fits in. But there is no indication here how it can be fed in. The supply model is for calculating the supply of manpower by training. It has nothing to do with the consultation time. Supply model is about pre-existing registrants, newly eligible registrants, how many of them are from local graduates, how many from non-local graduates, whether there will be retired doctors, and can male doctors work longer hours and female doctors shorter, and that will give rise to the number of FTEs. But consultation time, I think it is a demand from patients. It should be regarded as a demand-side factor. So it should be considered from the total number of visits and then for conversion into FTEs. Now, I am trying to test the validity of your model. There are factors affecting the demand for manpower. Rising expectations, which will mean longer consultation time, and an aging population. So to test the model, we will have to see how factors we can think of can be fed into your model for making projections. So further on, can you... All right. Now, if members have any questions, show of hands, please, because I can ask plenty of questions. In the coming days, we will have the opportunity to see your computer model. Because a computer model, after all, is set up by men. As for new model, it's easy. I can draw one too. So we have to know how a certain factor can fit in before we can discuss. Perhaps in future meetings you can come back and tell us about this. Mr. Vincent Fang?
Second round. Well, to me, I would say that it is difficult to be very accurate if you adopt this model. At most, you can have something like a framework. Now, in the case of doctors, yes, we have got 400 plus instead of 300 plus in relation to medical school graduates. But then for a doctor to become very experienced, and then if he chooses to retire, after years of experience, how many more doctors would you need so as to fill the gap to provide the same level of efficiency? Have you taken this into account? So you need to have this assumption. Say, for example, a consultant doctor retires, you may need 5 new doctors to fill his place in total. And then to test the accuracy of your model, let me not talk about what happens in the future. Let me talk about the present day situation. If we get today's data and if we feed everything into it, then I think the shortage of doctors that is generated from the model when compared with the figure of, say, for example, 400 suggested by the government, I want to know whether the two figures would be the same, the one generated by your model and the other one in the mind of the administration. So I think it all depends on the assumptions that you have adopted for building the model. Am I right? Mr. Chairman, for the second question, simple answer, yes. And that's why we are designing the model. And after that, it is important to test it. Mr. Fang is right. We are going to use historical data and current data so as to find out whether the figures generated are more or less the same as what we have got in mind. Now, everywhere people say that we have got a shortage of doctors. If the outcome of running the model is that we are fine, then there must be something that we have to look into. Yes, you're right to say that there will be a framework, and then in the future, regularly, say, for example, in 2 or 3 years' time, we have to refine the projection all the time. We hope that in the long term, we have something which is more reliable. Even if you know that next year we lack 50 and the year after next we lack 200 doctors, you can't really do much in the short term. What is important is that we want to look at the future, 5, 10, 15, 20 years down the road. So the model is mainly for the longer term. For the short term, as I have said, since last year, we have already increased the number of places in medical schools. We didn't wait for the model to be ready. We have already taken initiative to increase the number of places by 100. You might want to know why we could not have done more, but then we have to look at the capacity of the two universities. And secondly, the Medical Council has already planned to hold an additional licensing examination per year so as to facilitate the medical graduates returning from overseas. Again, they are not waiting for the outcome of the model. And then when the model is ready, we look at the picture in 10 years' time, 15 years' time. We want to know about the gap. And then we'll take a longer vision. And then we'll have more time and ample time to look at the expansion of the medical schools, for example. As to the experience of the doctors, maybe Dr. Johnston
can predict the shortage of doctor in terms of experience as well, not only the numerical figure, but also the experience. 但係 before you answer, let me just finish my piece. 就係話，就算佢個模型。
Well, even if the model can tell us as to how many more doctors we need, say, for example, doctors with 5 years, 10 years experience, I think the reality is that you can't do much about it because a fresh graduate cannot instantly gain 10 years experience. But I think we can resort to other means to, say, for example, attract overseas doctors to come to Hong Kong, medical graduates to return to Hong Kong to work. So we'll try to see how we can fill the experience gap. Mr. Chairman, I know my time slot is about to finish. I think the most important factor that would affect this model is that in the next 5 years or 10 years, do you think that the public-private sector partnership will be successful? If it is successful, then it will be much better. Well, when you talk about the PPP, you still have to look at the current situation. In Hong Kong, 90% of the services are provided in the public sector, 10% in the private sector. Irrespective of what we do, I don't think we can change the ratio drastically. we can't say make it 7 to 3 because we have got 20,000 beds in the public sector, 4,000 only in the private sector. So if you want to increase it to 20% while lowering the ratio in the public sector to 80%, you're talking about an increase of 4,000 hospital beds. So you can't really expect much change within a short period of time. So on the one hand, we have the health protection scheme. We hope that for those who are capable will take out medical insurance and then they can have a choice. Well, in Hong Kong, we have told everybody that you can always come back to the public sector. But if you are covered for minor conditions, if you want to have a better living environment, you may want to go to the private hospitals. Now, 4,000 beds would not be adequate. We are looking at expansion of the private hospitals. So in the future, the number will increase from 4,000 to 6,000 hospital beds. But then there are constraints. So the public-private ratio cannot change drastically within a short period of time. It won't become 50-50. This is not realistic. Maybe it is sort of going from 90 to 10 to 86 to 13, something like that, or 16. Dr. K.K. Kwok. 2 points that I agree with the PS. Now, the models are highly academic. It will be difficult to address the needs in reality. I think you made 2 points, but I'm not convinced. You talked about health insurance. You talked about public-private sector partnership. Allow me to say this. Whether you induce the citizens to take out medical insurance, thinking that it will be the long-term solution, I have reservation, huge reservation. Public money should be spent on public health care. As to whether it can be used to subsidize the citizens to take out private health insurance, I have reservation. And then the model will always be lagging behind. I think we all recall the days of Dr. Yo. I think at the time we didn't have money to recruit doctors, and so we suspended the increasing the number of medical graduates. Now we have got more places, but I'm afraid that one day the picture will change again. Now, currently, many doctors are leaving the hospital authority, experienced ones and the middle management. As you have said, the private sector can at most absorb 10% of the demand, so it will saturate at a particular point. Now, for the GNO, as a result of the changes to the type 2 babies, we do not see any GNO doctors leaving the hospital authority. So I want to know, in your model, what can you do to accommodate changes rapidly? Say, for example, in public hospitals, we find it difficult to retain manpower. Many people are leaving the public hospitals not just because they want to have a higher level of income. Rather, they find that they don't have any sense of satisfaction at all. They see no future in the hospital authority. I think it's a fact. Dr. Kwok, sorry. Perhaps you weren't with us when we started our meeting. I said that 2 minutes for questions. And then there won't be a time limit for the admin to give answers. So there's no need for you to make so many comments. Yes, let me finish my question. How can you make sure that the HA's personnel management can be reflected in your model? P.S. Let me answer the question about lagging behind. Dr. Kwok said that in year 2003, because of the economic downturn, the fresh medical graduates were not recruited by the government. It was a grave mistake. So we want to use the model to prevent repeating this mistake. At that time, we didn't know how many doctors we needed. At that time, we said that we couldn't afford that many graduates, and so they were not taken up. Now, for this model, I think we can anticipate how many doctors we need in 5 years, 10 years' time. Maybe in a particular year, the hospital authority may not have money to recruit the fresh graduates. With this model, we can tell the hospital authority not to be so short-sighted. This is because in 5 years, 10 years' time, we need that many doctors. So there is a duty to make sure that we've got sufficient doctors. Back then, there was nothing for us to back up our arguments. We could not convince others that there was such a need. Now, for this model, we can look at the medium term and the longer term so that we won't be affected by short-term changes. So even if one day we haven't got money temporarily, we know that there is a long-term need, and so we must give this priority. Well, for the other question, the morale of the public doctors, I think the model can't help. I think you know that we are currently having a review of the hospital authority. One factor being distribution of resources, working environment of doctors, the morale, how we can retain the manpower, how we can enhance training so that they have a sense of satisfaction. Now, for doctors in active service, more than half of them are in the public sector. So this is always our cornerstone. To answer your question, it is not that we're trying to kick out the people from the public sector. As I have told Mr. Fang, even if we had wanted to do so, we can't because there are constraints in the private sector. However, in Hong Kong, both the public and the private sectors are doing very well. I think the citizens should be given the choice. And for those who are covered by medical insurance, they have got value for money. So they should be able to make use of their health insurance. So it's a matter of empowerment so that the citizens can exercise their choice. It's up to them to say how much they want to share. Now, it's quite unlike the case of the USA because the citizens were asked to take out health insurance, they had to pay their own bills. Yes, we have a huge demand, the population is aging, but then we're returning the right of choice back to the citizens. That is, for those who can afford it, they can take out health insurance, and when they fall ill, they can make up their own mind to go to the public sector or the private sector. But then the government won't be forcing any choice on the patients. The government won't expel anyone from the public sector. Now, at least 10% of the population is covered by health insurance. We want to maximize the value for money. P.S. We're limited by time available. I just want to ask a very simple question. I read this model, Mr. Johnston. You haven't actually divided it into public and private sectors, right? Correct.
But we have a big problem in Hong Kong, and that is distribution of public and private sector. Now, if you just look at the number of discharge or the total number of bed days, now if you take the public and private sectors together, well, we already have a manpower surplus. Because, as you know, specialists are mainly shared by the private and public sectors half-half, and for general care, 10% in the private sector, 90% from the public sector. So if you cover both the public and private sectors, then at once, I can see that your model has not addressed the uneven distribution of specialists of doctors in the public and private sectors. So if you use this model, there will at once be a surplus of manpower because the split is 90-10. All right, I'll ask Mr. Johnston to reply. Please be very brief because we must end by 4:30. I've just been told by the secretary that we have meeting after this. I want to reserve 45 minutes for Professor Yeo. All right, the distribution. When we talk about the split of 1 to 9, we're talking about tertiary care. Hong Kong, most primary care is being provided by GPs. So 5,000 doctors in public hospitals, 5,000 in private practice. But the majority of these are general practitioners providing outpatient care, so there cannot be a very direct comparison.
In terms of the
distribution
capacity, this distribution between the public and private sector and the quote, underutilization of the private doctors in the market. Well, I'm saying that because the majority of the private practitioners, they are providing primary care.
Yes.
Yeah. So if you compare the specialists with the hospital authority doctors in terms of the utilization.
They're not compared. They are individually projected. So they're independently projected and then brought together at the end. So the projections are for each sector, public and private, and for each setting, outpatient or inpatient, or as Professor Lee said, it includes other sectors as relevant to perhaps nursing, and they're independently projected.
Well,
I can still think of loads of questions. However, we must leave time for Professor Yeo. Perhaps we need another session on manpower planning and projection on Dr. Johnston's study in particular. So we may need another meeting for that. Can we now go on to Professor Yeo's study on professional regulatory frameworks? You know, it's difficult that we can have both professors in one meeting. So while we may still have questions on manpower projection, perhaps we have to defer to future meetings. We must go on to item 4 of our agenda, reviewing professional regulatory frameworks for healthcare professionals. I think the PS has already given us an introduction to this. So, Professor Yeo, can you please give us your presentation now? Thank you, Chairman. If you don't mind, I will do the presentation in English and then turn to Cantonese again in replies. Okay.
Our task in the Chinese University to review the professional regulatory framework for healthcare professionals. The 4 objectives. One is to look at the experiences outside Hong Kong. The second is to look at our current system in Hong Kong in the different professions. The third is to analyze similarities and differences and identify areas that require attention and highlight emerging challenges. The study areas are 7. We're looking at legislation, regulatory and supervisory structures, undergraduate training, registration and licensing processes, accreditation systems, mechanisms for upholding professional standards and continuing competence, and mechanisms for detecting and dealing with professional misconduct and poor performance, and looking at overseas graduates. The study design is in 2 phases. We've finished the first phase, which is to review international models, looking at Hong Kong's review, and then making recommendations. The main data collection methods for 2. One is to look at policy papers and review papers, authoritative monographs, and information provided by regulatory bodies internationally, and then doing international visits and interviews of regulators and experts in other countries. The review of the international literature showed that the main purpose of professional regulation is threefold. One is ensure minimally acceptable standards of care. The second is provide accountability and reassure patients that professionals are deserving of trust. The third is to provide guidance about best practice and fostering improvement. So we're moving forwards from just looking at minimally accepted standards to look at ways to improve the quality of care. In the literature, there are 4 themes. One is the Self-regulatory arrangements, because most countries have self-regulatory arrangements for professionals, but it varies considerably in terms of whether it's complete self-regulation or in partnership between professions and the public, so-called co-regulation. Regulatory bodies, we see that there's more lay involvement, and that the regulatory bodies are becoming more accountable, and adjudication is sometimes seen as an independent function. In terms of quality improvements, there are attempts to look at how to improve the quality of care using certification and recertification, particularly in the US. And professionalism is seen to be complementary to regulation, as it ensures patient safety and quality of care, which is not a sanction against medical error. Just a range of the mechanisms for regulating health professionals. This is in the US, but it's got applications for other jurisdictions as well. Licensure is the granting of legal permits to practice. Registration is a compilation of lists of individuals who have satisfied in authority they are qualified to practice. So registration is usually associated with licensure, but they are separate mechanisms. Certification is acknowledgement of a predetermined level of achievement. It's usually set at a level above minimal acceptable standards. So certification usually looks at more than just the requirements for licensure and registration. Rehabilitation certification to ensure that practitioners maintain and collect appropriate evidence to attest to standards of the practice and demonstrate continuing competence. Credentialing is, this is particularly for private providers and payers, where a systemic collection, review, and verification of the professionals' professional qualifications using paper-sharing data and for individuals in the particular activity. And this applies specifically for some of the procedures that require surgery or invasive procedures where people look in terms of the credentials of the practitioner in terms of how many they've done, the quality of their work, so they're then credentialed to do certain procedures or for certain practices. And privileging is usually the grant of permission to perform specific professional activities. We have looked at the different models in Australia, Singapore, Malaysia, US, Canada, in mainland, in Taiwan, New Zealand, Germany, and Finland. And we've looked at the 7 professions: doctors, nurses, dentists, Chinese medical practitioners, pharmacists, and other health professionals. The visits that we've done are to UK, Australia, Canada, Singapore, Malaysia, and Taiwan. Context is that there are many jurisdictions. This is a growing topic for discussion, and there's a growing network of those involved in the regulatory processes, and there's a rapidly changing terrain. There are 10 key messages. One is that regulation, the reform of regulation, is seen to protect, for the purpose of protecting patients and improving the quality of care. Legislative changes is usually required to reform structures. Policy and organization for an overarching common principle of governance is emerging. So because in many jurisdictions, they find that many of the professional regulations vary from profession to profession. So they see the need for there to be an overarching common principles for the regulation of all the professions. And most jurisdictions are moving towards self-regulation in partnership with the public. Lay representation is becoming the norm in many countries, and relationships with governments and regulation standards by healthcare systems and institutional regulations vary from jurisdiction to jurisdiction. Compulsory continuing professional training and continuing professional development is the norm. And there's an emerging emphasis on not just looking at minimal standards, but for detecting and dealing with poor performance and improving the quality of care. And in many jurisdictions, the roles of the councils are being separated, and I'll give some examples later. And overseas graduates are admitted in different ways in the different jurisdictions. Most of the changes are triggered by increasing public expectations for greater accountability and transparency, and often triggered by scandals and some political interests. And the main aim, as I said, is to protect patients and ensure patient safety and improve quality of care. Some of the examples of reform in Australia, they now have a single national scheme for accreditation registration. UK has proposing mechanisms to simplify the current complex arrangements, to remove inconsistencies of regulations in different professions. So they are proposing one legal framework for all the professions. So these examples of the umbrella legislation, so that there's a nationally consistent legislation in the single act. So they have one single legislation to include all the professions, so there's consistency. So these examples of what's happening in Australia, New Zealand, and Canada, they already have umbrella legislation, Finland as well. UK is proposing to change it. So the main purpose is to enhance common principles of regulation and oversight of the different regulatory bodies. There's a movement from the concept of right to self-regulation towards more co-regulation, either in partnership with the public or having government oversight. And there's a much greater emphasis on openness, accountability, and engagement of labor representatives. The types of self-regulation in Canada and Germany, there's government-sanctioned self-regulation. In UK, Australia, and New Zealand, there's co-regulations, partnership either with the government or with the public or the community. And in jurisdictions like Singapore and Malaysia and mainland, in fact, there's very strong government oversight, because in Malaysia and Singapore, the Director General of Health is the registrar of the professional councils. And in China, obviously, the oversight is directly in the ministry. There's a global trend towards increasing more lay people in boards and review panels and inquiries. So this is just a table of some of the percentage of lay representatives. The ones that don't have any lay representatives are usually have very strong government oversight, as in Singapore and Malaysia. And in the US, these are state boards. There is also a role of health system and institution regulators, which play a supplementary role in health professionals. And the government plays a strong role, as I said, in Singapore, Malaysia, mainland, and in Taiwan. There are system regulators, like especially in the UK, where other than the councils, there are also different commissions, which are systems regulators that look at the quality of care, like the Care Quality Commission, National Institute for Health, and Clinical Excellence. So they separate some of the supervisory and regulatory functions to different system regulators. In the US, the providers of insurance also take part in regulations. And as I said, that in UK, they have a host of different other provider regulators. Compulsory continuing professional training and development is the norm in most countries. And there's also movement towards revalidation, recertification. In UK, the revalidation has started in December 2012, and recertification is already in place in the United States. So professionals are supposed to demonstrate that they have updated their skills and ability, and they need to be recertified for them to continue to practice. CBT requirements, you can see that most jurisdictions have compulsory CBT, continuing professional development requirements, but for certain jurisdictions it's only for specialists. And some countries still don't have it, like in Malaysia, but they are now moving towards it. In Hong Kong, it's mandatory only for doctors, for specialist doctors and specialist dentists. And there's a trend towards detecting and intervening early with poor performance to improve the quality of care. Of course, to be able to do that, you need to have standards. So for assessing poor performance, so you need to have standards by which you can measure, and it provides a threshold against poor practice which can be assessed. There's also a greater separation of roles to reduce the conflict of interest. Investigation and disciplinary functions in the regulators is being separated, and some jurisdictions have separate accrediting bodies as well. In Australia and New Zealand, they have an independent body to receive complaints, New Zealand has a health practitioners disciplinary tribunal to hear and determine disciplinary action. So their professional councils don't deal with disciplinary procedures. It's an independent health practitioner disciplinary tribunal. And UK has a similar medical practitioners tribunal, which provides hearing of services, and the General Medical Council does the investigatory role. The last item is overseas graduates. They are admitted in different ways. There are different criteria for employing international graduates. Many jurisdictions have recognized this as qualified overseas institutions, but most of graduates still need some form of professional assessment and require a period of supervised training. So although they may have a list of medical schools that they recognize, but it's not that they can register, but they are given provisional registration, but they've got to work under a period of supervised training. Assessment standards is also done by professions with the regulators in UK. The reasons for admission of overseas trained doctors is twofold. One is because there's a shortage of particular types of health professionals in particular areas, and the second is to promote internationalism and promote experience sharing. Criteria is that in Singapore they have 155 institutions that they have a list of registrable basic medical qualifications. Malaysia is 374. But these institutions, the graduates from these institutions can apply, but they are given registration, but they have to work under the supervision of a qualified medical practitioner for 2 years. In Australia, they have 3 different pathways for registration for overseas graduates. They have a so-called standard pathway, so the people have to be assessed and sit exams and do the usual supervised training. But they also have a competent authority pathway. So there are certain institutions that they recognize, and for these graduates from these institutions, they are considered so-called competent, so the pathways are shortened. And then this pathway for specialists that they require. So they have a variety of pathways to bring in the graduates in Australia. So it's not just one system for all. Finally, the implications for Hong Kong. We've asked questions of, does regulation need reforming in Hong Kong? Do we need new legislation? Is there a need to adopt common policies? Or do we need to have an overarching umbrella body for professional regulation? Is there a need for enhanced role of government and of lay representatives in professional regulation? Do we need more lay representation? What's the relation of government with health system regulations? Should compulsory continuing professional training and development be introduced? How do we detect and intervene with poor performance and improve the quality of care? Do we need some separate roles to separate some of the roles of the regulatory bodies, such as adjudication or investigation accreditation? And do we need to change the way that we accept overseas trained healthcare professionals? I think that's the last transparency. Thank you, Chairman.
All right. The floor is now open to members for questions. No questions? Yes, you have a question. Dr. Joseph Lee. Thank you, Mr. Chairman. I would like to thank EK for his very comprehensive presentation. Well, you are a specialist, and probably the Permanent Secretary has got some basic ideas in mind. Now, I think for certain medical professionals, they need to undergo certain reform. Now, I want to know whether you think that we need an umbrella organization to oversee that. And then there are also 10 to 20 plus other bodies are not yet under statutory regulation. So do you think that they should be brought under the regulatory framework as well? Permanent Secretary. Maybe Professor Yao would like to give an answer. Let's share with us your observation. It's better for you to give an answer. P.S. First of all, I think it is quite unlike what the honourable member has said. That is with some basic ideas. No, we haven't got the basic ideas. That's why we need the study, and the study hasn't been finalized. So Professor Yeo has to continue with the work. What I want to emphasize is that every place has got its own development, but it is true that across the board there have been many changes. Population is aging, and even in the UK, you know that there were a number of very serious incidents, and that gave rise to the need for reform. Now, in Hong Kong, we have to check what has to be changed, and it should also be in line with the aspirations of the community. And then to the dozen or so professions not yet regulated, yes, we are already looking at that. The Ombudsman has got a report, and on our part and the Department of Health, we're studying the report. We'll try to see if they are to be regulated, in what form. First of all, they don't have a large number of professionals, and then the mode of service is quite different from that of the conventional professions. So if we are to bring them under regulatory work, or oversight, should it be in the same way? We have to study the matter. So, short answer to your question, we are still studying the matter. Anything else to add, Dr. Yo or Professor Yo? Well, we met with different professionals from different disciplines. Yes, I think a lot of institutional setups have to be changed. Different professionals have got different needs. I think the government is still looking at ways to change. Some are more technical, others are more administrative in nature. Different medical professions have different needs. So I think later on the government will take an overall view. So we take a general view, but of course different professions also vary. For those not yet regulated, as the PS has said, at the initial stage, we also took a quick look. Although that's not the core of our work, we have looked at the experience overseas. That is, whether and how they are regulating those disciplines that are not yet absorbed in the regulatory framework. You still have a minute or so, 2 minutes. For the 15 allied health professions, I think the total number is great, 7,000. Those spread over 15 different allied health professions. They contribute a lot at the primary and secondary level. They're helping the citizens. If you don't have an effective mechanism, now according to the Ombudsman, it is a case of maladministration. Otherwise, the case would not have reached the Ombudsman. As Professor Yo has said, we need an umbrella organization, so that they're grouped under the umbrella organization. But of course, this is one of the options. Under CAP 359, we have the Supplementary Medical Professionals Ordinance. I want to know whether that would come in helpful. P.S. I think Mr. Lee is right for listing out the factors. Well, we have to look at the history now. If we want to regulate the supplementary medical professionals, should we go for something more revolutionary, or should we adopt a more conventional mode? Of course, we have to look at the nature of their work, the risk posed to the public, as well as the cost effectiveness or the cost benefits of the regulatory work. Yes, you want to protect the public, but of course it will have a bearing on cost, will also affect the professional development. So we're trying to see whether we can adopt a more modern approach in regulating such professions. In particular, they don't receive professional training in Hong Kong, so they are overseas graduates, and they are the finer details that we need to look at. Simple answer is that we are following up on this. You have 20 seconds left. You don't need that? All right. Mr. Vincent Fang. Thank you, Mr. Chairman. First of all, I would like to thank Professor Yeo for your very detailed report. And I think it is something urgently needed by the healthcare sector. You spent a lot of time on reading up the literature on this matter and also the case in overseas countries. The hospital authority has this arrangement that is restricted registration. And for such medical or such healthcare professionals, do they have to sit an exam? But I think the restricted registration is good for 1 year only, and every year it has to be renewed. Or limited registration, rather. Limited registration. Well, for them to come to Hong Kong, you take the better half of a year before you get familiar with the environment of the HA. So a year's time will expire soon. So is it possible to extend the duration from 1 year to 3 years? I think 3 years would be a more reasonable time span. Permanent Secretary, let me comment on the manpower issue again. It is not easy for someone to be promoted to become a consultant doctor. But then you may want to extend the retirement age from 60 to 65. By extending the age by 5 years, I'm sure it will greatly benefit the patients. Permanent Secretary, you also talked about the licensing exam. In early October, the Medical Council announced that there would be 2 exams per year. Yes, finish your question. Will Cantonese still be one of the requirements? Such a requirement will put many people off. And then to sit the exam, it is about the basic knowledge. Many specialists are not willing to come back to sit such a basic examination. So is it possible to change the format so as to encourage more doctors to come back to Hong Kong to take the exam? Permanent Secretary, Mr. Chairman, about the limited registration, I think everybody knows the problem. According to the law, the Medical Council is the authority to vet it. And then the 1 year duration is again prescribed by the law. I think if we see the need, I think perhaps we can talk to the Medical Council. But of course, we need to understand that under the law, this is the power of the Medical Council. As to your second question, that is the retirement age of the hospital authority. I think we are looking at the long-term manpower supply. If we do see a serious problem, we can certainly take up the matter with the hospital authority, because retirement age would be something looks like a short-term solution. Yes, you may extend the retirement age, but of course we have to look at the views of the doctors within the hospital authority. By extending the retirement age, the new batch of doctors will have to wait longer to get promoted, and they have fewer chances to gather experience. So we need to strike a balance. Perhaps instead of extending the retirement age, we can re-engage, re-employ the retired doctors so that we won't affect the promotional prospects of the doctors while we benefit from the experience. And we can still boost the pool of manpower. It is also attractive because for the retired doctor, there will be a greater degree of flexibility, because for a retiree, he may not want to work full-time. So this will be given consideration in the review of the HA. I just want to say that whenever something is related to personnel management, you have to look at the case of the existing staff. First of all, we need to check whether there is agreement that there is a shortage and whether the shortage is a serious one. But probably that's for the medium term and the longer term. So perhaps we can then, on the agreed basis, find ways to solve the problem.
So the simple answer is we are very actively following this up with the HA as well as the sector. What about 2 licensing examinations in a year? Regarding language requirements or bilingual requirements, because it involves professional quality, but will the test be? Can the test be taken in Chinese? No. But I understand that they can provide interpreters. There are 3 parts to the examination. Second part on English skills, English language skills, not on professional knowledge. The first and the third parts, clinical meeting with patients. I think that can be a test done in Cantonese or Chinese. Now I think he's talking about specialists. Right. He's saying that the language can be a deterrent. The language requirement can be deterrent. In fact, the licensing examination in Hong Kong can be taken in Chinese, right? And experienced specialists, they don't want to be tested on the basics. No. There is the Cantonese requirement, the clinical test. Are you sure that it can only be done in Cantonese? I don't think so. I think Mr. Fang is saying that for experienced specialists, they have been working overseas for so long, and if they come back and if they are required to take the clinical test in Cantonese, they may not feel comfortable. But as far as I understand, this is not a problem. I think the licensing examination can be taken in English. Dr. Kwok, may I remind you that the timer or your time limit is just 2 minutes, and we do not have speaking limit for official replies. Thank you. 2 simple questions. Professor Yo is here. I thank him for his study. I believe this is just an interim report. When can we have the final report? And when will you start the reform? Well, you asked whether we need new legislation. I think the answer is yes. Otherwise, the reform cannot be implemented. Dr. Joseph Lee mentioned other healthcare professionals other than doctors. They are, to quote a few, dietitians and clinical psychologists. Please don't think that their work doesn't have any impact on the public. Well, because people can claim to be these 2 types of healthcare professionals without any certification, but the government must protect the public. Will the government give priority to these 2 industries first? Right, CU Hong Kong has done this study for us, and this is an interim report, and we believe that in the coming couple of months we can have the final report. After studying the report, we will come back to this subcommittee and brief members on the government's response to the recommendations in the report. We hope to complete the work in a few months' time after the final report is available. And for regulation of dietitians, well, it may not be covered in this report because this report is on healthcare professionals. They're already subject to some form of regulation, such as doctors, nurses, dentists, so on and so forth. For other allied health professionals, they cover a wide scope. Now, dietitians, for instance, and clinical psychologists, they regard them as professionals, and this is more obvious, but we cannot adopt an across-the-board approach. We will first consider allied health sectors that have a greater impact on public health before we consider the type of regulation. But will it be as strict as that for doctors? That would involve further consideration, because as you know, the secretariat of these disciplinary bodies are funded by the government. So if there are new healthcare professions that require regulation, we will consider them in the future. Maybe in a year or so, the Department of Health is trying to formulate a model with references from other jurisdictions. We don't want to use an approach as stringent as that for doctors and nurses due to historical reasons. Well, you still have 54 seconds. So you don't want to adopt that regulatory approach. I beg to differ. Either you don't regulate these healthcare professionals, or else you should have certain standards. And I'd like to know the regulatory cost. And have you discussed with the professions concerned? Would they be willing to foot part of the bill? For instance, the Law Society and Bar Association has their own regulatory system for registration and disciplinary sanctions, and the costs are mainly borne by these organizations. So perhaps you should discuss with these professions. Yes, all these factors are being considered. A more complex issue is, take doctors and nurses as an example. They are trained by local institutions, so it's easier for us to set standards. But there are other healthcare professionals not trained in Hong Kong. Some of them are involved, are rather alternative, and many of them are trained overseas and come to Hong Kong for practice. So we have to learn from what other jurisdictions are doing. Well, a simple answer is we do appreciate this point, and we are studying these issues. When we have some ideas, we will come back to the subcommittee to report to you our position and to invite your views. You have 6 seconds. Do you want to spend that 6 seconds or not? If not, I have 2 questions. One for Professor Yeo, the other for the PS. Professor Yeo. Annex C is comparison of regulation of doctors in Hong Kong and overseas. First, you look at the nature of the regulatory body. So you talked about self-regulation or high levels of regulation on the part of the government, and then the composition of these bodies with different percentages. Appointment by the regulatory bodies. Is appointment done by the government or by these bodies? And self-regulation, I'd like to know where the members come from. Can you please tell us? And P.S. Professor Yeo is doing an academic study, so he can disregard the political issues. But according to Article 142 of the Basic Law, how much room does the government have to maneuver when it comes to legislation to govern regulation of bodies? Well, in many jurisdictions, these bodies, members of these bodies are appointed by the government, and sometimes they advertise to invite interested parties. People are invited to apply for such positions in the UK. And in some places, such information is not available because the regulatory bodies are given the free hand, and we don't have information on this. Yes, we can seek information from these jurisdictions if you're interested. What about the appointment of lay persons? Is it also by appointment? Yes. P.S. What about the provisions in the Basic Law? Can the government really legislate to cover the regulation of these self-regulatory bodies? Well, because they are self-regulatory bodies according to the Basic Law, so we'll have to consider our local situation and also learn from overseas jurisdictions to see where we can improve. So we have to discuss with these regulatory or these professions first. For instance, CBD, all over the world, there is compulsory professional development. So we will see how this can be done to enhance protection for the public without causing too much disruption. Even if we have to legislate, we have to go through LegCo first. And before any law is enacted or proposed, we have to consider whether it is in conflict with the Basic Law. Professional self-autonomy is enshrined in the Basic Law. Thank you. AOB. We have one very important AOB item. The subcommittee will continue to operate because the subcommittee has been established for over a year, and we have to report to the House Committee. Usually, we can only operate for 1 year. We will seek an extension of our term from the House Committee. Okay, on the 15th of November, I'm going to apply to the House Committee on your behalf. Date of our next meeting, the 9th of December, a Monday at 2:30. Administration. According to the administration, I would like to discuss the design of the insurance policy, regulatory framework, and also claims dispute resolution. But it appears that people are more interested in the detailed product design and also funding for healthcare insurance schemes. Can we discuss that in December? Sure. What about the model? Can we be shown the mathematical model for manpower projection? I understand that it is something very preliminary. Still, we want to try it out. And also the distribution of doctors in the private and public sectors. Although Dr. Johnston told us that the projection is done independently, still you cannot control the flow of manpower from one sector to another. What if there is brain drain from the public sector to the private sector? So please see whether you can provide us with the mathematical model. Today we have a briefing on that. We need the actual model ready for calculation, and we'll have a number of questions. After I have summed up my questions, can we meet with Dr. Johnson again? So please let us take a look at the model. I'll discuss with Hong Kong U to see whether that can be provided. Well, you own the patent, right? Well, we will have to ask Hong Kong U what the model is about and whether the assumptions and key input data can be given to us. I'll see what further information I can get. Now, Chairman, when the report is published, I'm interested to see. Now, Dr. Johnston will provide the medical model. I'd like to know what data will be fed into the model by the government. For instance, the consultation time per person can be 10 minutes. No, the 4 approaches are a review of approaches being used, and this model mainly use the second. Currently, HA is using the second approach. Now, I don't know how to. I don't know about the machinery, but I think the administration should show us when different data are fed into the program, what will be the results. Please discuss. I'll discuss with the secretary. Perhaps we should form an expert group because lay members may not understand the model very well. All right, thank you very much. Date of next meeting, 9th of December. Design and funding of healthcare products. Thank you.